is there something from a medical history standpoint that suggests there should be or could be change radiographically, or change that could predispose someone to the need for endodontic treatment? And I mentioned to you earlier that I don't like talking to endodontists because I have to admit my errors and tell you that I've treated the wrong tooth. Well, this is one that's pretty embarrassing as well. So if I had faces out there rather than just my own face sitting alone in my office, this is one where I might get a chuckle, and it's not you laughing with me, it's probably you laughing at me. So this patient presents in October of 2010 with a necrotic tooth number 24, and a root canal is done. In May of 2011, he presents again with symptoms, and another root canal is done, this time in tooth number 23. And these teeth are necrotic upon access. He has no response to thermal. These teeth are percussion and palpation sensitive. It's exactly what you would expect to find with necrotic teeth. However, he has no history of trauma, and obviously there's no caries history. So we're getting a little bit perplexed. He returns in July of 11, just a couple of months later, and the pain is back, but now the pain is back in tooth number 26, and a root canal is done. So he has 3 teeth treated endodontically from October of one year till July of the next, and he looks at me and says, hey, what's going on? All of these teeth, again, were necrotic upon access. And I said, there aren't many things that are going to cause necrotic pulps in the absence of dental work. There are a few things out there. Sickle cell trait. There's the potential for, excuse me. So sickle cell trait is certainly something, but he's a Caucasian, so we're not worried about that issue. And I said, not too many things. It could be dental dysplasia, but you don't have that. We can tell that radiographically. Or vitamin D resistant rickets. And he says, well, yeah, I have that. And I was dumbfounded. I was dumbfounded because I was mad at myself because I never paid enough attention to him as an individual. I always met him in the chair. And if he would have, as he stood up and walked away from me on that day after we had the discussion, he had clear and obvious rachitic changes. So he was always sitting in the chair. I never paid enough attention to just look at him to see the changes that were there. And it was obvious, just by looking at him. And I was also a little bit perplexed because, I showed him the medical history, and I said, we've got this line on there that says other. This would have been a really good thing to put down as other. So I take the lion's share of the blame. He took a little. We took a shot of one of the molar teeth. This is in his mouth, so you get to see the large pulp space and the dental significance of vitamin D resistant rickets we'll talk about in just a moment. So it's hypophosphatemia caused by a renal loss of phosphate into the urine. It's going to lead to systemic changes, bowed legs, which he had, very short stature, which he had, again, clear and obvious rachitic changes. From a dental standpoint, poorly mineralized dentin, high pulp horns with dentin clefts and large pulp chambers, basically leading to the development of necrotic pulps in the absence of any trauma, caries, or restorative history. And then lastly, after I've thought about the dental history, after I've thought about the medical history, the pain history, and the radiographic findings, the last thing I really want to think about is what's going on from a dental standpoint. Because again, I know I'm going to get there. And I want to know, do the pieces of the puzzle fit? Here we see a large carious lesion, a tooth that doesn't respond to a thermal stimulus, a tooth that's percussion sensitive. He has spontaneous pain. So many factors that suggest a dental issue, an issue of endodontic origin. And I'm not trying to reinvent the wheel each time I see patients, right? I'm trying to make it be systematic and straightforward and understand that in the endodontic realm, this is what we're going to see. We're going to see far more horses than we are zebras. But I always want to consider the possibility of a zebra, especially when the case doesn't behave exactly as I think it's supposed to. So what can I conclude from all of these diagnostic uncertainties with pulp testing, radiology, even pathology? Well, when we look at Seltzer-Bender, their classic study on differential diagnosis of the pulp, the bottom line is, if we brought one of those guys into my office, I've got my cone beam sitting behind me and microscopes in each of these rooms, and showed them nickel titanium instruments, I think they'd be floored, right? I think they'd be really astonished at the changes that we've made in the endodontic community. But if we asked them to do some pulp testing, they'd get some cold and put some cold on some teeth. They're going to do today the same thing that they did 30 and 40 and 50 years ago. So although we've advanced in our ability to treat teeth and do things differently, when it comes to being able to make an accurate diagnosis from a pulp standpoint, we really aren't doing anything different now than we were then. So does it matter? When we look at the incidence of pain and what's going on, 16%, when we look at the incidence of pain and what's going on, 16% of the general population have experienced pain within the past 2 weeks. Many of you probably feel like you've experienced pain in the last 60 minutes. And over a 6-month period of time, what percentage of Americans had pain with toothache type pain being the most common? And that's 22%. That's a big number. So it's those types of numbers that keep us all busy in our endodontic practices every day. And of course, this is what we're trying to avoid. This is out of pathways of the pulp, but we've all seen some folks like this, maybe not to this degree or extent. But the bottom line is, this is going to be someone that has some sort of pain issue, misdiagnosed, and ultimately overtreated from an endodontic standpoint. And I referenced this article earlier when we were talking about pulp testing and the limits of pulp testing and the potential to overtreat roughly 7% of the time. This is Alan Law's study with Don Nixdorf looking at the frequency of persistent pain following root canal treatment. And it's not pain because there's a problem from an endodontic nature. It's the persistence of pain of non-endodontic etiology. And it's a meta-analysis, and they found that with the higher quality studies, roughly 7% of folks were not getting better. So the gap that we have in pulp testing, 7 to 10%, is corroborated by this evidence just on the backside, looking at the same issue, but from a completely different perspective. So the bottom line is, my diagnostic limitations are somewhat inherent in what we do, in the subjective nature of the testing that we do, in the subjective nature of the 3D or 2D imaging that we might have, and in what we've seen before. From my perspective, having seen some of the weird and the wild in my past lifetime influences me in how I look at cases today. I always have in the back of my mind the thought that maybe I am looking at a zebra rather than a horse. And that's led me to make a whole bunch of what I think are interesting and non-endodontic diagnoses in my clinical practice of endodontics over the last 16 years. I've diagnosed folks with cardiac conditions, although I got to tell you, I'm not sure I got either one of those right. So the bottom line is, I had 2 patients, each with pain. They felt it was dental in origin. The testing was not conclusive. No endodontic treatment was done. And both of them ended up having cardiac issues within a day or 2 after seeing me. So it's not like I got those right and said, oh boy, I think you're having a heart attack. I think you need to get over to the cardiologist. But I didn't get it wrong either, in the sense that I didn't know that it was endodontic in origin and I didn't treat. And if we look at a variety of the other things, ranging from odontogenic cysts, tumors, and even when we get to the bottom of the list, I've even diagnosed necrotic pulps and irreversible pulpitis cases a few times in my career. So it's not all about the weird and the wild, right? Most of the time, as endodontists, we're going to be dealing with lesions of endodontic origin.